Great to be here. We're going to talk to you about calcium and show you a case in the near future. If you want to register on the app, you can get access to all the content, and we'll let you know about future courses. The course relevant to this is in the near future in Belgium, where it's a unique interactive course where we've actually got 2 virtual cath labs, and we'll be doing hands-on atherectomy-based treatment, IVL, cutting balloons, OPNs, everything. So you'll be learning everything you need to know about calcium and also putting it into practice in a real cath lab environment, which is very exciting. So I'm going to talk to you today about eccentric calcium. Quite often we hear a lot about concentric calcium and nodular calcium, and this is the forgotten child, if you like. And I've termed this talk the hidden hazard. Now, a very simple framework for calcium management is that you need to know it's there, that's identify, then you modify it, then you assess it, and if you're happy with your assessment, you move on to end therapy. So let's start with the hypothesis that eccentric calcium is the most common morphology, but also it's the most difficult to treat. And that's obvious if we think about the progression of calcific plaque. It starts at a single location and then it spreads out from that. So it nearly always starts as eccentric calcium, and concentric calcium is further down the line. So it's quite easy to miss or even ignore when you do see it. So for example, take this case. This is an angiogram of a left main ileocaudal view. There's a disease at the left main bifurcation into the LED. Looks pretty benign. Can't really see anything. But if we look on the IVUS, you can see there is eccentric calcium. And notably from the IVUS, when it's black beneath it, that means there's no penetration of ultrasound. And it's a marker of calcium density. And unfortunately, this operator didn't notice that. And you can see this is the consequence. And I'm going to try and explain to you why eccentric calcium is a marker for adverse outcomes, both in the short term, something catastrophic like this, but also in a more indolent fashion in terms of stent failure. And this is old data going back some time now, showing that the calcium threshold before you see anything in the angiogram is actually quite substantial. So you could miss up to about a quarter of calcium on an angiogram, even with an arc of 180 degrees. And the same applies with our advanced imaging technologies. OCTs often purported to be the most advanced in terms of calcium because of its higher resolution, and AI supposedly helps us in identifying calcium. But if you're not careful, if you set the threshold for identification too high, you're going to miss a lot of calcium. Here you can see that we've lowered the threshold to 90, and all of a sudden this vessel's got calcium pretty much throughout its length. Here's a similar example on IVUS, and once again, our eyes are drawn to severe concentric calcium. But if you look in the longitudinal view, where is the artery black? Because where the artery is black is a sign of reduced vascular compliance and also risk. You can see there's a lot of eccentric calcium. But what we do know is that even in academia, things tend to occur in discrete dichotomous variables. That's not the case in biology. These morphological patterns often occur simultaneously. And we can refer to that as morphological heterogeneity. Here you can see there's a nodule distally. We come more proximally, there's eccentric calcium. More proximally, still concentric calcium. So we've got all 3 types within the same lesion. And this is data from the CAD3 group of studies, where they looked at calcium morphologies according to ARC. And you can see that eccentric calcium was there in 65% of lesions. So it's the most common. I think that's not up for debate. But to date, our ways of conceptualizing calcium are too simplistic. They often considered the most severe part of calcium. There's a relatively low penetrance of imaging, as we talked about in the first session. There's no consideration of how to treat based on morphology, and we don't understand what is the threshold for treatment in eccentric calcium. So there's a lot of work to be done. And you could ask the question, is intravascular imaging enough? Because we don't get any information on density. All the technologies have got limited penetration of the, whether it's ultrasound or light waves. Even OCT, if the calcium is thick enough, does not penetrate. And ultimately, we get a 2D representation of a 3D structure. But as we've heard from the first session, things are changing. And now we can get a 3D volumetric representation of calcium, in which we start to understand the density of calcium and therefore how severe or how difficult it is going to be to treat, and even how to treat, because we can show wire bias, and we know that's important for atherectomy-based techniques. Here's an example of what lesion-specific density means. Low density on the left, right up to Hounsfield units over 1,000 on the right, mature calcium. Because what we're trying to do from our imaging is understand the pathological basis of the calcium. Because calcium can be a honeycomb type structure, or it can be a very dense structure, and obviously they behave very differently. But from an operator perspective, if we're treating this calcium, perhaps the single most important takeaway from this talk is that the minimum stent area post-treatment is often not at the site of maximum calcium. So why is that? Let's look at that. When we see this sort of longitudinal view of a plaque, our eyes are drawn to the MLA, the area that's the tightest. We say, oh, that's a severe stenosis. I have to treat that severe stenosis. That's our first order problem. But of course, our goal here is to treat the lesion in its entirety. And the site of maximum calcium, we know from the data, is frequently not at the site of the MLA. So what we tend to do is that we concentrate our technologies where the lesion is tightest and where the calcium is thickest. So we treat them best, whether it's the arcs here 125 or 215. We treat them very well, and we put in a stent which is longer than the lesion length, as it has to be. And that generally means we get the MSA at a point remote from where we've targeted our treatment. And that's really important, because from an arterial perspective, the artery just cares about flow. It doesn't care you did a good job treating where the calcium was the most severe. It wants you to treat the whole lesion, the whole implant zone. Let's give you another example of what I mean by implant zone. Again, you see this right coronary artery, dominant right coronary artery, critical lesion, heavily calcified. Your eyes are drawn there. I've got to treat that critical lesion. Looks really tight. I'm going to use rotational atherectomy. So we do rotational atherectomy, and then we look at the lesion. We look at it across the implant zone, and because we've used rotational atherectomy, we think we've treated this lesion. We've treated the MLA. You can see on the OCT that it's extremely disrupted, and you can see proximally the classic rota tunnel, where the rota has almost gone into the wall of the artery. But critically at the bottom, we've left unmodified an area of eccentric calcium. So if we put our stent in without modifying that area, what we'll get is a well-expanded stent at the MLA, but our MSA will be at the point where we've under-recognized this residual eccentric calcium. So this is data again from the DISRUPT series of studies. In 97% of cases, the MSA, that's the most narrow part of the stent, was not at the site of maximal calcium. This isn't just a random finding. This is a consistent finding which will happen in your practice if you're not aware of this. And 70% of the time, there was calcium at the site of the MSA. So the cause of the stent being narrowest is still calcium. It's just calcium we're not treating because we're not understanding the implications of the implant zone. And the average amount of calcium, eccentric calcium, only 130-degree arc. So this arc of calcium we think is not significant or not important, actually is the biggest predictor of stent outcomes and therefore patient outcomes. And we know this is from Ziad's, some of Ziad's work showing that we have to get our stent area to a certain size, otherwise we're going to run into problems with MACE. But not only that, eccentric calcium is also a risk factor for perforation. And this is because it causes something called regional variations in compliance, which is a long-winded way of saying that half of the artery is resistant to expansion and the other half of the artery is very elastic. So here you've got another LEDD1 lesion. Let's look at the imaging. Classic eccentric calcium. It's black, deep to the ibis, so it's probably dense calcium. And critically on the right, you can see the trilaminar structure of the artery, so that's elastic tissue. So what happens when you blow up a balloon? Let's find out. Now again, I would say this is probably one of the most important learning points. If you look at the balloon on the right, you can see that the wire is hugging the lesion. So the wire is no longer centered. So the balloon is expanding away from the calcium. And actually the diagonal here makes things worse because it expands a lot away from the calcium. And what happens here? Another bad outcome. So eccentric calcium is a risk factor for perforation. We looked at our data in London. We looked over the last 5 years for epicardial perforations. We're pleased to see 90% of imaging use. In 90% of cases, the cause of the perforation was balloons. Our old tried and trusted friend was causing problems because we weren't understanding the pathology that we were treating. And most of the time, 3/4 of the time, it was eccentric balloon expansion. And 90% of the time, this was due to eccentric calcium. Not concentric calcium, not nodular calcium, eccentric calcium. This is what we would call a black swan event. And one of the things that it doesn't happen very often, but when it does happen, it changes how you think about things. And that's our challenge with education. Not how you have a black swan event, but how you learn from somebody else's black swan event so you don't have to make their mistakes. So this is your opportunity to learn from that. Eccentric calcium is a significant risk. So you have to recognize it, you have to understand the device you're using to treat it, and you need to change behavior. Here's an example of recognizing it. So you've got calcium very visible without contrast. It means you lower your threshold for identifying calcium to 90 degrees. So now you're seeing a lot of calcium on the left, whereas you don't see any on the AI on the latter two screens. And you can see on the IVUS that there's, again, lots of eccentric calcium which you need to treat. Remember to use the tools that you've had for years. One of those tools is enhanced imaging, where you can see from how the balloon inflates as to whether the lesion's prepared or not. And remember that balloon inflation does not equal plaque preparation, particularly where it's eccentric balloon inflation. So it's, again, on the right, the balloon is expanding, but to the right. So it's expanding away from the calcium. You could ask more fundamentally, what are you trying to do with eccentric calcium? Change compliance, make the artery more elastic, or reduce the volume of calcium? It depends, because we know that balloons work in concentric calcium if you can apply enough force, and that doesn't matter whether they're scoring balloons or standard balloons. With the ablative technologies, you've got to actually come into contact with the calcium. And lithotripsy, well, it's a different animal, and I'll explain that in a second. And this is another reason why we miss eccentric calcium, because we don't pay enough attention to balloon inflation. So here you've got concentric top left, eccentric bottom left. Quite subtle changes in the eccentric balloon inflation. It looks superficially okay, but you can see it's not. You've got this eccentric expansion again away from the calcium, but with the concentric restriction, it's either there or it's not. And remember, balloons don't have a choice about where they expand. They just expand according to the resistance that they encounter. So if the calcium is rigid, they expand away from it into the less rigid part. And here's an analogy of this. You've got a group of little friends all holding hands. This was Mike and Kevin and Carlos and Colin and I last night. We were filming this for some reason. Whereas there's the three little isolated friends on the right. So let's pretend they're not arteries. We put a balloon in the middle and we expand that balloon. With concentric calcium, the force is dispersed equally and it'll fracture at the points of weakness. With eccentric calcium, it will expand away, and that is where the risk lies. So to labor the point further, we expand the balloon and it expands into the elastic part of the artery, and that creates tears at the shoulders with the calcium, and if the balloon is oversized, and it can be sized to the EL and be oversized, then you can risk perforation. Again, another example, balloon inflation on the left, a lot of eccentric calcium in the OCT. Stent is implanted, you've got your D-shaped stent because we've not modified the plaque sufficiently. So, is rota the answer? Well, sometimes, but it relies on wire bias because it allows superficial debulking of calcium by coming into contact with the calcium and then thinning it and allowing secondary treatment. And if you want to know if the imaging works, or if the ablation works, pass an imaging catheter. If you can't pass it, then go for an upfront ablative strategy. If you can pass it, look to see if the imaging catheter is in contact with the calcium, because if it is, the ablative strategy will work, and if it's not, it won't work. IVL is different because it's an acoustic waveform. And think of it like a little package of energy that's going out into the artery. And it deposits the energy where there's an impedance interface. And that means usually the difference between calcium and non-calcific tissue. So if we look at this animation, for example, when we expand the balloon, we get the same balloon type effects that we'll see with any balloon. But then we get these three special features of IVL, which is caused by the collapse of the cavitation bubble. First of all, compressive force, then shear stress, and then in the back edge of the calcium, tensile forces. So you get this crazy paving effect, which is highly selective for calcium. And we can say it's highly selective because the results support that there's no difference in terms of MSA according to ARC, and there's no difference in stent expansion according to ARC. But the reality of treating complex disease is that this heterogeneity may mean you need more than one ways of treating calcium. So back to our example of the tight right coronary artery. We've done the rota, we've created a pathway, we've modified the critical lesion, but we've almost created this eccentric lesion at the top, you can see on the right, where we've got disruption in the rototunnel, but no effect at all on the opposite side of the artery. So what do we do about that? Do we put in a stent? Well, we know the answer. We put in a stent, we're going to get a D-shaped stent, we're going to get our MSA there, and the patient's not going to thank us. Even if we get a bigger burr, that's not going to help either, because increasing the size of the burr up to 2.0 is still not going to touch the other side of the artery. So this is where we use IVL, because we know it can treat eccentric disease as well as concentric disease. We apply the therapy. We don't have to worry too much about whether that's a safe thing or not, because the safety profile is very good. Now you can see the difference in the balloon inflation. On the left of the screen, the wire is hugging the calcium because it's not modified. On the right of the screen, there's now space for the balloon to expand into the calcium because it is modified. So this is post-atherectomy, and this is post-IVL. You can see if the question in your mind was, can IVL treat eccentric calcium? There's the answer in visual terms. Treats it very well. Big fractures at the bottom, fractures at 3 o'clock, as well as the original rotofractures. So I'd say in summary that eccentric calcium is something which has been under the radar. It's not really talked about a lot, but it's really common. The risks of it are underappreciated. And understanding your devices will help you to target treatment. Heterogeneity is the rule. It's what biology dictates. And frequently that means that we need to understand mechanisms of actions and we need to understand complementary therapies. Thanks for your attention.